So, good afternoon. My name's Dr. Paul Mason and I'm a doctor from Sydney in Australia. And today I want to take you all on a journey looking at exactly what it is about cholesterol that might be a problem with respect to our health. And I'll tell you straight up, LDL cholesterol is not one of them. Not high LDL anyway. We're going to look at everything from the idea of small dense particles, oxidation rates, and we might even have a look at particle count and lipoprotein Ldl. And then we're going to finish by touching on statins. And I'm going to include some hopefully quite revelatory data regarding the true side effect rate of statins. So by way of disclosures, I have a website. So I know that's a pretty disappointing disclosure. I run a metabolic clinic with another fellow Australian doctor, an orthopaedic surgeon by the name of John Scher, and aspirationally at least, one day we're going to populate this website with some useful information. So let's begin with the biggie, LDL. LDL is almost uniformly known as bad cholesterol, or at least to anybody with a medical education. And this pejorative nature of the term says it all. People are afraid of LDL, worried they're just going to drop off their perch because it's high. Now, because of this, there's now more cholesterol-lowering drugs out there than you can poke a stick at. And it seems that every second patient who comes into my door is on a statin drug because they're trying to lower their LDL, which is funny really, because LDL doesn't really appear to be that bad at all. This systematic review from 2016 looked at 19 cohort studies with over 68,000 participants. And of these 19 studies, 16 of them found an inverse relationship between LDL cholesterol and all-cause mortality. That is, the higher your LDL cholesterol, the lower your all-cause mortality. So last year, a new patient came into my room, and when I saw him, I thought to myself, this guy's an athlete. But this wasn't my sports medicine clinic, this was my metabolic clinic. So I thought, somebody at the front desk has made a mistake, they've booked him into the wrong clinic. So anyway, he gave me this letter. You see, he had recently applied for income protection insurance that required medical testing. And he had failed. So this is him. This photo was taken a few days after he received the letter. He's 48 years old, a regular exerciser, and he also happened to be on a high-fat ketogenic diet. This is what's called a Dexa Scan. This is his Dexa Scan showing his body composition. The blue areas represent lean tissue, and the red areas represent fat. So I wasn't getting it. Why was this guy considered too much of a medical risk to insure? Well, it was his cholesterol levels. These are his actual test results, the ones the insurer used to make their decision. And here are the US values there. And on the right-hand side, you can see the standard reference ranges which his values were meant to reflect. And based on these reference ranges, his LDL of 6.7 or 259 in US units is where he came unstuck. The insurance company was worried that this high LDL level would cause him to have a heart attack. After all, atherosclerotic plaques are filled with LDL and cholesterol, so high circulating levels must cause it, right? No. This myopic perspective ignores the fact that both LDL and cholesterol are essential for good health. Indeed, they're essential for life, full stop. And LDL itself can also be good, and it can also be bad. And the process of turning good LDL into bad LDL isn't driven by fat in the diet, it's driven by carbohydrate. This is because carbohydrates, even the so-called healthy complex carbohydrates, they're literally made of sugar. Glucose molecules sequence together. And when you eat carbohydrates, that same glucose enters your circulation, and there it can damage the LDL particles. So let's take a look at exactly what LDL is. Let's first clarify some terminology. The term cholesterol is often used loosely to refer to these lipoproteins here you see up here on screen, on the sole basis that these lipoproteins carry some cholesterol inside them. But that's ridiculous. That's like mistaking a bus for one of the passengers. And it's as absolutely ludicrous as it sounds. Cholesterol itself is a small molecule absolutely essential for life. And it's very, very different to the much larger and much more complex lipoproteins that you see here. So there's 5 major classes of these lipoproteins, and we can differentiate them out based on their size and their density. So on the bottom left here, you can see something called a chylomicron. Now, chylomicrons are formed after we eat, and that's how we digest fat. But by the time we do a fasting blood test, these have disappeared from the circulation, so we don't need to worry about them anymore. And if you cast your eyes up to the top right of screen to the HDL, this is smallest and densest lipoprotein, and it's colloquially known as good cholesterol. Higher levels are generally favourable, but we're not going to really focus on that much today. Instead, I really want to focus on the 3 particles in the middle: VLDL, IDL, and LDL. These stands for very low density, intermediate density, and low density lipoprotein. And I've linked these 3 lipoproteins by arrows to demonstrate that they're actually the same particle. They start out as VLDLs, which get released from the liver, and then they circulate around the body, and as they go, they release some of their lipid cargo, and they donate it to tissues for energy supplies and things like that. And as they do, they shrink a little bit. It's like a deflating balloon. And we can identify these particles. They've got a unique protein that's embedded in their outer coat, and that's called an ApoB100. And every one of these particles has exactly 1 ApoB100 protein contained within the coat. And this is a representation of the ApoB100 here, and you can see it winding in and out of the LDL particle. Now let's have a look at the normal life cycle of one of these ApoB100 carrying lipoproteins. So it starts with secretion from the liver, and it's worth noting that VLDL secretion is actually significantly increased in states of insulin resistance. So the VLDL particle delivers some of its triglycerides to cells around the body and reduces in size. First of all, it becomes an intermediate density and then a low density lipoprotein. And these LDL particles can then be recognised by these special receptors on the liver using the ApoB100 protein, and the livers can then recycle the LDL protein back out of the circulation. This is normal human physiology. Now, this here is a bit of a close-up of the ApoB100 protein, and I've just identified a region here which we call the Ldl receptor binding site. So this is the part of the ApoB100 that the liver can recognise. Without that, the liver can't recognise this particle. Persona non grata, you're not coming in here. And sugar can damage or glycate this region, sugar from carbohydrates. And this effectively will stop the LDL receptor on the liver from being able to recognise it. And another point, this process of glycation also fractionally shrinks the LDL particle, just enough for it to be known as a small dense particle. Ever heard of the small dense LDLs? Well, this is where it starts. But then we can further modify LDL. The process of glycation generates a lot of what we call oxidant stress, and this can also lead to oxidation of the LDL particle. And we now call this one a glyco-oxidized LDL. And this process of oxidation can also lead to shrinkage of the LDL particle. Now, it doesn't have to be glycated to be oxidized. Oxidation can occur for a number of reasons. Interestingly, if you've still got an intact ApoB100 receptor site, the liver can actually take this oxidized LDL out of circulation, and there it can actually create oxidative stress to the liver, and there's now an increasing body of literature that demonstrates it's the oxidative stress to the liver, in part contributed to by this mechanism that actually leads to fatty liver disease. And furthermore, if we put in a potent antioxidant like something like melatonin, there's very good evidence that we can ameliorate some of the effects on fatty liver disease. But with enough oxidant stress, we can actually damage the ApoB100 protein, so it can't be taken up by the liver, and that's irrespective of whether it's glycated or not. And that little bit of extra oxidation also just makes it that little bit smaller. So putting all of this together, you can see we've got these different populations of LDL which vary in terms of their size and density based on degree of oxidation and glycation. And the key point here is that some of these states are associated with damage to the ApoB100 protein, which will prevent the liver from recognising it and being able to take it out of circulation. So we end up in a situation here where the modified LDL particles are unable to be taken up by the LDL receptors as normal. And over time, they begin to accumulate. And this leads to what we know as an increased LDL particle count. Now, because they're small, the volume of these LDL particles isn't that great, but their number certainly is. And that's why the particle count is actually a much better predictor of cardiovascular risk than the total LDL volume. Now, this study was published just last year, and it was based on a 15-year follow-up of nearly 28,000 females, and it was looking at the development of peripheral vascular disease. And you can see that while the volume of LDL cholesterol didn't seem to matter too much, the particle count certainly did. In actual fact, it was quite significant. So let's look at why these particles are so bad and how exactly do they end up in the blood vessel wall. So for oxidized LDL to enter into an atherosclerotic plaque, it has to pass through the lining of the artery. And first of all, it has to breach this brush-like layer, which is called the Glycocalyx. And you can see a cross-sectional view of a blood vessel here, and you can see the furry lining, which is actually the Glycocalyx. Now, the Glycocalyx serves several important functions. It regulates the tone of the blood vessel, the degree of muscular contraction, how much blood's going through. It also helps protect the underlying layer, that layer of endothelial cells you can see underneath that are joined together on the sides. And high levels of blood sugar damage the Glycocalyx. And this graph here shows the volume of Glycocalyx before and after only 6 hours of elevated blood glucose levels. One point to note here is that oscillating blood sugar levels are even more deleterious. In actual fact, an average, if you have a look at these charts here, they're from a continuous glucose monitor from some of my patients, you can see that the average blood sugar on the top tracing is 4.7 compared to 5.6 on the bottom tracing. But I'm far happier with the bottom tracing because it lacks these oscillations which are associated with extra oxidative stress. We also have these special proteins we can ingest in our diet that are called lectins, and they can also damage the Glycocalyx. So after we ingest them, the lectins can actually cross over the intestinal barrier, and subsequently they can enter into the circulation, after which they can bind to and damage the Glycocalyx. And what you can see here is that fluorescent-labelled wheat germ agglutinin, which is a lectin, is actually binding to the interior of this blood vessel, binding to the Glycocalyx. The presence of oxidized LDL in the circulation, though, is probably even more significant than the other factors. And the graph here demonstrates how the presence of oxidized LDL precedes the development of atherosclerosis. You can see the volume of circulating oxidized LDL decreases, shown in yellow, at the same time that the size of the atherosclerotic plaque increases, shown in red. So why is oxidized LDL so bad? How can it increase the rate of transfer of LDL across the wall of the blood vessel by 20 times? Well, it's particularly damaging to the Glycocalyx. And this disruption of the Glycocalyx results in a loosening of the tight junction proteins which are actually holding the epithelial cells together. And this allows these oxidized LDL particles and cells called circulating monocytes to actually migrate into what we call the subendothelial space. And once there, these monocytes turn into another type of cell called a macrophage. And these macrophages express something called a scavenger receptor. And this scavenger receptor can actually recognise and bind to the damaged LDL particles that the liver receptors could not. And this results in these damaged LDL particles being ingested by the macrophages, leading to the formation of something called a foam cell, which is basically a macrophage just packed with lipid. And this is what it looks like under a microscope. And these foam cells are contained within atherosclerotic plaques. And this is the end result. This is a left anterior descending artery of the heart, and this is more commonly in medicine known as a widowmaker. It's kind of useful. And you can see how the internal lumen of this artery is so narrowed that there's only a trickle of blood that's getting through now. That's not a good state to be in. So that's the process that causes blockage of arteries. You have oxidized LDL and elevated blood sugar levels, and they're significant contributors. So eating saturated fat might increase your LDL level, but it doesn't make it go bad. It's eating carbohydrates that makes the LDL go bad. And then we come to the question that's relevant to my patient. How do I know if he's got oxidized LDL in his circulation? Well, we can actually analyse LDL using centrifugation. So this is an example here of a healthy LDL sample. So first of all, we place it into the gel, and then we spin it down so that the different lipoprotein populations move through the gel to different distances based on their size and their density. And the dark lines in the gel represent different populations which have travelled different distances. And the results are presented like this. And you can see the dark lines within the gel actually match the peaks in the graph, and the height of the peaks actually represents the overall volume of each LDL or lipoprotein subfraction. And if we put it back into the nomenclature that we saw before, you can see you've got the LDL, IDL and HDL also demonstrated there. So let's see how an unhealthy LDL population would look on this. So I want you to just focus on this yellow box, and then we'll put in the unhealthy sample here. And what you can see is that once this has been spun down, you can actually now see two distinct populations. And if we had a look at them on a graph, under the LDL section, we would actually see two distinct peaks or two distinct populations. This is now starting to look not so good. But we saw before that we've got more than two potential populations of LDL. Well, these are some of my other patients. This is a triple bunger. Or perhaps, this person should start on their wine cellar pretty soon, or they should change their lifestyle. So we can actually test for oxidized LDL in another way, and we can use something called antibodies. So the surface particles or molecules on the surface of oxidized LDL are changed from normal, and we can use something called antibodies, which have very specific affinity for some of these changed particles. And basically, these antibodies will only attach to oxidized LDL and not to native or healthy LDL. And this is the results from one of my patients using this test, and she was shown to have an elevated oxidized LDL level. Now, if you understand how this antibody test works, then you can understand something called lipoprotein Ldl. Now, this lipoprotein Ldl has been strongly shown by the evidence to be associated with adverse cardiovascular outcomes, but there's a lot of confusion about why that is. It seems that a lot of people don't really understand what's going on with it. So what is it? Well, it's basically we take an LDL particle like this with an ApoB100 protein winding around it, and then we get something called a little ApoA protein and attach it. That's what lipoprotein Ldl is. It's just this little extra protein just being attached to the side. Now, it's often been said that lipoprotein Ldl levels are genetically determined, but this doesn't stack up with the science. For instance, in babies, the average lipoprotein Ldl level is about 5 times lower than in adults. And when we look at the levels in babies, there's absolutely no differences based on gender or racial differences. So pretty strongly suggesting that genetics aren't really playing a big role. Rather, lipoprotein Ldl levels reflect changes in metabolic health. Now, there's a little bit of information that I haven't given you yet, and that's because the lipoprotein Ldl will only have an attraction for an LDL particle that's been oxidized. So this picture's not correct, because that's a non-oxidized LDL. So in reality, lipoprotein Ldl is not going to attach to that. And that means if the particle is not oxidized, it will not form lipoprotein Ldl. So the presence of this whole molecule, the lipoprotein Ldl, is nothing more than a marker of oxidation. So it's absolutely analogous to the antibody-based blood test that we can do for LDL cholesterol, for oxidized LDL. And this is why the predictive value of oxidized LDL and lipoprotein Ldl is so similar. They're effectively measuring the same thing. And when we do look at the intervention studies on reducing oxidized LDL, we also see we get reductions in lipoprotein Ldl. They're just travelling along together. Now, I'd just like to briefly talk about statins and their influence on LDL. So remember that the healthy native LDL is removed from the circulation by the Ldl receptors expressed on the liver. Well, statins, they inhibit something called HMG-CoA reductase, and this actually results in the increased expression of these receptors on the liver, and that's how they actually lower LDL. More receptors, it takes more of the cholesterol out of circulation. Except, we've just learnt that these receptors don't bind to oxidized LDL, you know, the bad ones. So they take the good stuff and they leave the bad stuff behind. So by reducing the total volume of LDL particles, there's going to be less LDL particles around in the future to be oxidized. So in the longer term, they might actually be able to reduce oxidized LDL levels, but the ratio between the two is going to be much less favourable. And this ratio between oxidized LDL and healthy LDL has actually been strongly associated with poorer cardiovascular outcomes. And this study actually was based on a statin study of 16 weeks of a very high dose statin, and it actually reduced or increased the ratio of the oxidized LDL to the healthy stuff by about 10%. So based on this kind of study, you'd think that the likely benefit of statins would be pretty minimal. And you'd probably be right. So most people take statin medications to stop themselves from dying. But that's not the way you should think about it, because you're going to die anyway. What they might do, they might delay you dying. So that's a much better question to ask. If I take this medication for X number of years, on average, how much longer will I live? So this review was based on data from 11 studies, over 90,000 participants, and it followed them up for 4.5 years. So just a quick show of hands here. Who here would take a statin medication if it would increase your lifespan by 1 week? Okay, what about 1 year? Oh, come on, guys, it's not that bad. 5 years. Come on, yeah, I mean, 5 years is good, right? 5 years is good. So let's have a look at what this study showed. So if you had a history of cardiovascular disease and you took a statin as per the protocol here, you'd get another 5 days. But what happens if you didn't have heart disease? Most of you guys haven't had heart attacks before. Well, then you get 3 days. And in experimental studies where LDL levels are reduced, they also have similar findings. So this was a really neat study. So it was performed on people with a condition called familial hyperlipidemia, which is a genetic condition that just puts your LDL levels through the roof. And it makes a lot of doctors nervous. So when a new drug came out, a group called PCSK9 inhibitors, a lot of doctors got really excited, because for people with both genes affected in this condition, it could lower your cholesterol, your LDL levels by about 60%. Absolutely massive reduction. So what did this study find the clinical benefit was of this kind of reduction in this population? Well, unfortunately, there was no statistically significant findings. But, the thought was there. So then the question is, what about side effects? That's something, we always argue about that. We've got the Sir Rory Collins, who reassures us that the rate of side effects from statins is less than 1%, and I'd really like that to comfort me, but it's a bit tough because it's totally false. It's actually closer to 25%, about 1 in 4. And thanks to this paper on PCSK9 inhibitors, we have the data to prove it. Because you see, one of the entry criteria of this study was that participants be on statin therapy. Except when I went to have a look at all the data, the study participant information, it seemed that not all of them were. And that's because some patients simply can't tolerate statins. So by reviewing the data and crunching a few simple numbers, I was actually able to come up with a true side effect rate of statins. And these were big numbers, so you can see the numbers that they're based on there. So, thousands of people there. So 1 in 10 patients could not tolerate any statin that was tested at the lowest available dose. And the criteria were very explicit. You had to have a medically documented intolerance to at least 2 different types of statins, including at least one of those being used at the lowest possible dose. And even then, 1 in 10 people couldn't tolerate it. And what about standard dose statin therapy? Well, 1 in 5, 20% of people couldn't tolerate that because they had a level of side effects that was too significant for them. And the definition of the standard dose statin therapy is 50% of the dose, the maximum dose in a single tablet that you can get in the market. That's basically the way you can think about it. And despite all of these people who had these side effects being excluded or not taking statins, 5% of them still had clinically diagnosed myalgia or muscle pain, far in excess of the background rate. So that would suggest, adding on that extra 5%, that at least 1 in 4 people are intolerant of standard statin doses. And that's where I'll finish. So please remember, it's the carbohydrates, not the saturated fat, that damages LDL. And the benefits of statins have probably been exaggerated, and the harm certainly appears to have been minimised. I think everybody should have access to accurate information so they can make their own informed decisions. And my patient, his lipid profile was awesome. Thank you.